intervention radiologist as well as the diagnostic radiologist at Calgary, Mayfair Diagnostics, Canada. And she has lots of publications related to the topic, and we have requested her because pain management is where I personally say that India is lacking behind musculoskeletal. So we especially requested her, and I thanks Dr. Sara for accepting our request. And now I think we should proceed with our webinar. Dr. Sara, the participants at present are 28. Don't feel that there are only 28 participants, because many participants are on YouTube also. So they are seeing it on live on YouTube.
Wonderful. Okay, well, good afternoon. I'm going to just try and share my screen here, and you can let me know, Dr. Arun, if that is working on your side. Let me find my correct one. And let's see if this, can you see that there?
Yes.
Yes.
Great. So good morning, and thank you for the introduction, and I'm glad our timeline has worked here. If you
can you zoom your screen? Means there is an option of size possibly, because the slides appear very small.
Let me try. Let me try something else here.
Just see if there's a full screen option on your, just go to the full screen option in your PowerPoint.
Yeah. And yeah, 1 second, bear with me.
Dr. Sarah, is your video enabled?
It should be, yes.
No, we are seeing just S. We are not seeing your video.
Oh, okay. Hang on a moment. And I'm just going to try to maximize this. Sorry, excuse me 1 moment.
No problem.
Yeah, it should be on full screen here. Let me just try again. And I'll try to share this other screen with you. All right. Are you able to see that any different now?
No, we are just seeing it.
Not yet. Okay, let me try again here. I've got a few screens going on, so tell me if you see anything yet. I'm going to try, hang on, let's try this now. Okay, hang on. I'm just now in the midst of this. 1 second.
Share your screen. I think previously we were able to see your PowerPoint. Only the size was slightly small. So
yeah, I'm just trying to see if I can get it to enlarge here. 1 moment, and yeah, okay, 1 second here.
Jane.
I'm just going to stop that for a moment.
We saw it for a second.
Yeah, and I just had to, it won't let me start it. So let me try this once more.
Workstation में ऐसे आएगा. I think इसमें workstation पे तो ऐसे ही आएगा.
Is that any larger?
I think it's okay.
Yeah, that's okay, I suppose. Yeah.
Okay.
Workstation.
Yeah. Yeah.
My apologies. Okay, so let's start again. So good morning, my time. Good afternoon, your time. So thank you for inviting me to speak. As you mentioned earlier, Dr. Arun, that certainly in our experience here in Western Canada, radiology has great opportunity to be involved in interventional musculoskeletal care. In our environment here, I would say that 80% of injections are done by radiologists. Certainly that there is a component of family physicians and specialists who are comfortable injecting, but we also know that many of them don't have access to ultrasound or fluoroscopy machines. And we know that the chance of them getting product in the right area of a joint is very difficult. So we've had a very positive experience here, and I'd like to share some of that with you. I've been asked to do 2 separate webinars. And the second one, I wanted to talk more about some of our procedures and approaches to different injections. But interestingly, there has been quite a significant change in osteoarthritis management in the last year, which I would say not many people get excited about osteoarthritis, but it actually does lead it's a nice pathway for us in terms of managing our patients. So I thought this was a good place to start. Some of it is a bit dry, I apologize, but I think it's worthwhile information to have as a baseline for starting treatment for those of you who haven't already. So I'm going to go over the epidemiology pathway, pathology, and the current interventional management based on new guidelines. Briefly, we're focusing mostly here on the management. Okay. So disclosures briefly, I am a member of our local bone and joint health network. I'm a member of a physician advisory board, both for Sanofi Canada and for PendoPharm. These are 2 companies that provide hyaluronic acid injections. Some of these slides are thanks to Sanofi Canada. So briefly then, we're going to focus today on the knee osteoarthritis, epidemiology, pathology, as I mentioned, the latest guidelines, and just give a case example of how these new guidelines play out in clinical practice. So osteoarthritis in Canada is not much different, in fact, from osteoarthritis in India, based on recent publications. Here in Canada, it affects about 13% of Canadians. That's all osteoarthritis, with up to 400,000 new cases every year. Notably, the lifetime risk of symptomatic knee osteoarthritis is up to 44%. In India, I read a similar percentage of 43%. And this is considered one of the largest burdens of disease, of non-transmittable diseases affecting humans. It's obviously a significant cost to many healthcare systems here in Canada, up to $195 billion, mostly due to loss of productivity for these patients. And notably, not only is it a significant burden right now, but we're expecting it to double by 2020. That's based on some of these initial papers, which are dating back to 2011, and again by 2030. So this condition, knee osteoarthritis, is on the rise. So briefly, we all know what osteoarthritis is and traditionally what's been happening, but I just wanted to highlight a few new interesting concepts in the treatment and the pathology of osteoarthritis. So we know there's cartilage thinning and tearing. We know there's marrow edema. We know that there is subcortical bone changes and BML, or bone marrow lesions, which is part of the grading now. We know there are bone spurs, and synovial thickening is a component of osteoarthritis as well. I just highlight the diagram showing you our typical 4 stages of osteoarthritis based on X-ray that we would gauge as a Calgary-Lawrence stage, which we know on X-ray can be suboptimal assessment of osteoarthritis. Sometimes we are seeing joint effusions. There's a concept of a wet osteoarthritic knee or a dry osteoarthritic knee, and that may ultimately affect how we treat these patients. The other two components I just wanted to mention, there actually is thought that there's an inflammatory component induced by shear stress in these patients. So that might explain some of the synovial thickening and joint effusion that we may more typically see in an inflammatory arthropathy. Crystals are seen, calcium phosphate, up to 100% of patients have been seen to have these crystals, and up to a third of patients can have CPPD crystals in the joint. Again, these may be factors in why patients will respond to certain injections and not others, and may, once we understand more, give us a clearer pathway of how to treat these patients. So the key components and presentation for knee osteoarthritis, again, is known to us. They typically present with pain, stiffness or decreased range of motion, and a sensation of buckling or giving way, which is a common presentation you'll hear from patients. On X-ray, we'll see the typical changes here with joint space narrowing over the medial compartment, which is moderate to significant, almost bone on bone, with some sparing of the lateral compartment. I will mention one of the poorly described articulations in the knees, the Patella femoral joint. Without a skyline view in appropriate angulation, it becomes very hard to quantitate. And some patients have purely patellofemoral OA, which is quite life-altering. So it's worth having a proper X-ray series for diagnosis. But nonetheless, osteoarthritis management is challenging. We know that our best prognostic chance for these patients is predicated on the earliest diagnosis, but unfortunately, it's a diagnostic challenge. Early osteoarthritis can be normal on X-ray, and we have limited testing at the moment available to us on the cellular status of a joint. Osteoarthritis has also been a therapeutic challenge traditionally. There are very few disease-modifying therapies, and we know that the better response is earlier. Certainly in our experience here, many patients don't get a diagnosis of osteoarthritis until it's at least moderate, if not severe. So you end up with a patient conundrum. Patients get stuck, not sure what the diagnosis is and not being managed properly. So early diagnosis of OA is very critical here. This is a busy slide, but just to show you where we've come from, this was a traditional treatment for mild to moderate knee OA, with the goals of therapy on the right, showing that we're trying to alleviate those symptoms that patients present with, the pain, the stiffness. We want to improve their function and mobility, and ideally, we want to slow the progress of OA. We know that conservative approach earlier, including weight loss, and some of the other oral medications here are what traditionally we've tried. And some of the injections down here where we have a role are considered later and often right before joint surgery. So this is what I would say the conventional thinking in knee osteoarthritis management is still. So that's why I think it's important for people to be aware of some of these new guidelines and recommendations that do change that approach. So here, for example, hyaluronic acid in knee osteoarthritis, so viscosupplementation, it's also called. These are some of the Synvisc and Durolane injections. You can see how this has evolved from 2014, various guidelines dating back to 2010 even. Many of them were very against having intra-articular hyaluronic acid injections. But with time here, as we've gotten longer in time and more, and certainly up to 2019, we're having guidelines start to change their opinion, suggesting that intra-articular hyaluronic acid is a very favorable recommendation for treatment in knee OA. So there are two particular guidelines that I'd like to talk to today. The first is an international guideline from OARSI, which is the Osteoarthritis Research Society. And the second is a local Canadian Arthroscopy Association, just making our pathway and our opportunities to provide patient care a little bit simpler. So the first is 2019 OARSI guidelines. Basically, it's for non-surgical management of knee, hip, and what they describe as polyarticular osteoarthritis. And this has been updated since 2014. They went through a very systematic review and provided this position statement based on 60 different treatment interventions. They involved orthopedic surgery, sport medicine, physiotherapy, rheumatology, as well as the primary care physicians. And the recommendations, as I described, were on these 3 phenotypes, so knee, hip, and polyarticular arthritis. But more notably, they're talking within this position statement about 5 comorbidity groups, which I'll talk about in a moment. Without getting into great detail, this is their overview of the methodology. Suffice to say that it was fairly thorough with panel and input and going through all the literature review to come up with a really robust set of guidelines. And what does that voting data mean? Well, in essence, if any level of 1A, 1B, or level 2 was considered a recommended treatment. So in essence, for the first 2, if more than 75% of those involved felt it was appropriate, it was considered level 1, and more than 60%, that was level 2. These recommendations were then further characterized into different levels of treatment. So there's a core treatment, which could be used by almost any patient. Primary treatment levels, also unfortunately labeled level 1A, and a secondary treatment level 1B and level 2. And basically these are additional levels. So if a patient doesn't progress or improve on a certain level, you can go on to the next treatment level. As documented on this slide, where we're starting at a core treatment, adding on additional levels, which I'll describe in a moment. And they use this then treatments and apply it to the osteoarthritic phenotypes and the comorbidity groups with a goal to provide more patient-specific recommendations. As I mentioned earlier, the concept of a wet and dry osteoarthritic knee, we're not quite there, but it is starting to tailor. How can we treat individual patients' presentation rather than osteoarthritis based on what we know traditionally? So here is their very, very busy graph. And I'm just going to walk you through a few examples. It's quite comprehensive, obviously. So across the top here, I recommend or describe the core treatment. So we're just going to talk about that. The feeling is that osteoarthritis education should be a standard of care. It helps engage the patient. It's very important. They talk here about land-based exercise programs, type 1, the strengthening and cardiovascular, and balance training or neuromuscular exercise. Interestingly, they've also included a mind-body exercise component with Tai Chi or yoga, which I think is really inclusive for a lot of patients. One of the bits of information we'll often share with patients regarding weight loss, which is the other key component here, is for every 1 pound of weight loss for a patient, their knee feels 4 pounds less. And that's a really encouraging number for patients who are trying to lose even a small amount of weight. Certainly makes a difference in terms of their symptoms. So core treatments, you're trying to get your patients engaged. Now, as radiologists, is this very practical in our day-to-day clinic? No, but it's where we overlap here with primary care physicians. Perhaps you have a multidisciplinary approach where they see sport medicine, who can manage these for you. The second level is where our role becomes a bit more significant. So now we're going to talk a bit about level 1, level 1B, and level 2 treatments. I'm going to go into these in more detail, but just a reminder, the comorbidities for patients they're trying to separate are those with no comorbidities compared to those with cardiovascular comorbidities or with gastrointestinal comorbidities. There are some slight nuances between them. So patients with no comorbidities, these are the most straightforward. The primary recommendations now are for topical Nsaids, and I'll talk about that in a moment. Oral non-selective Nsaids with a PPI or COX-2 inhibitors. And look what presents so early in this treatment pattern is suddenly intra-articular corticosteroids. This is no longer relegated to just before surgery. It is one of the, after patient education, one of the primary treatment considerations. Then they talk about gait, aquatic exercise, and self-management programs, again, considered important in patient outcome. If none of these are effective, the patient will go on to intra-articular hyaluronic acid injections with cognitive behavioral therapy and exercise combined for a more robust approach. But even so, intra-articular hyaluronic acid injection to be in level in the higher level treatment and earlier on is very reassuring for us, and it's good for patients. So just a few details about those treatments. Specifically, they're suggesting intra-articular corticosteroids are recommended for the acute or short-term pain relief. So if patients have an acute flare, this is a great way to start. If they have pain relief that's limiting their response to other treatments, intra-articular corticosteroids are valuable. But again, note, it's only 4 to 6 weeks of pain relief. We know that corticosteroids become less effective with time. In contradistinction, the intra-articular hyaluronic acid is also conditionally recommended, but this provides a longer-term treatment effect, up to 26 weeks, with a very favorable safety profile. So that gives patients 6 months relief. That again is very encouraging when we're trying to deal with something that's a chronic condition like knee OA. And besides, and I'll get into what they each specifically, pain relief more so with steroids, but notably here, the patients also have functional improvement. So getting back to exercise is useful. The other thing I just wanted to mention is the Nsaid risk mitigation. Traditionally, on our last typical or traditional diagram, I showed you Nsaids were one of the first recommendations. Now they're suggesting that you want to use these only for the shortest duration, only 1 to 2 weeks, 1 to 4 weeks rather, and always with gastric protection at the lowest possible dose. For those with cardiovascular safety concerns, naproxen is considered more safe, but I'll talk about the cardiovascular comorbidity in a moment. And the coxips are better for those with the GI concern. If the patient is having lots of pain management beyond what we can manage in these guidelines, it's important to note that these guidelines are suggesting a multidisciplinary chronic pain management program. That's sort of beyond the capacity of certainly our clinics in managing these patients. So the specific positive recommendations out of these ORC guidelines related to pharmacological treatments is that, as I said earlier, topical Nsaids strongly recommended for all knee patients. In our practice, sometimes when we're doing injections, we're providing the opportunity for patients to have topical Nsaids as well. We can prescribe those for patients. Sometimes they've already come with that tried by their family doctors. And again, we can see the benefits of this modest improvement over up to 12 weeks with very minimal adverse effects. The selective COX-2 inhibitors conditionally recommended for those patients with GI comorbidities, more favorable safety profile. Again, this is something the primary care physician should be managing. But of note is that intra-articular corticosteroids and hyaluronic acid injection conditionally recommended for all knee OA patients. So that puts us in a very significant role for those of you who are comfortable doing these injections early on in patient care. A few of the summary of the negative recommendations related to pharmacological treatments from ORC. Basically, Nsaids were played down. We want to be very careful in terms of prescribing those. They made a note about intra-articular stem cells and PRP. At the moment, they're strongly recommended against. What has changed, however, is previously they were not even evaluated. There is research, which I'll talk about in my next webinar, showing that there may be some value in these injections, but unfortunately the quality of evidence at the moment is poor. The quality of the studies is poor, and there's no standardized treatment. So we're not able to make recommendations yet for the role of these different biologics in osteoarthritis. Opioids strongly recommended against, which is no surprise given the background here of abuse and dependency that we're seeing in patients. And there's notably very limited or relevant benefit of patients with OA who try opioids. The most interesting of the recommendations was acetaminophen is not recommended. I'm not sure what your experience is, either with you yourselves personally or your patients, but there's not a patient, nor a colleague, nor a friend, nor a family member who has not tried acetaminophen for knee OA in my experience. But this meta-analysis suggested that it has very little to no efficacy in treatment of knee OA. And of course, there's the risk of hepatotoxicity. So we need to take that off of our traditionally, but very commonly assumed treatment guidelines. So in brief then, the change from 2014 to 2019, acetaminophen no longer recommended. Intra-articular corticosteroids and hyaluronic acid recommended initially the steroids for acute and short-term pain relief, and hyaluronic acid for up to 26-week pain and function relief. The Nsaids, not recommended, certainly with patients with comorbidities, cardiovascular comorbidities, and frailty. Opioids are strongly recommended against. PRP and stem cell, as I mentioned, and another one, duloxetine, is recommended only for patients with depression. Again, this is something managed at the primary care level. So I'm just going to walk you through a patient example of this and what this means for the treatment algorithm. So here, for example, is a 6-year-old female. She's got chronic atraumatic left knee pain. She has a BMI of 30. On the initial assessment, clinically, she has knee osteoarthritis. She also has hypertension and gastroesophageal reflux. Clinically, she presents with pain, but normal range of motion and no stiffness. She has no effusion, instability, or malalignment. And she's has good social network and no mood concerns. So based on this and the ORC program, she would go on to the core treatment, again by the primary care physician, unless you have the luxury of working in a multidisciplinary program. So this would be education, structured exercise, and dietary weight management. And then we'll go on to the patient-centered pathway. In her case, we try the topical Nsaids first. Again, that should provide some relief for up to 12 weeks. Most of these patients are going to have symptoms beyond 12 weeks. So if the patient still has symptoms, which in her case she does, then we're going to go on and we're going to offer her, probably because she has predominantly pain, we would start with intra-articular corticosteroids. And if her pain returns, then we will go on to offer her intra-articular hyaluronic acid for a more durable response of up to 6 months. Again, primary care will be managing aquatic exercise and gait aids rather. The patient warrants regular reassessment. And if she has ongoing symptoms, eventually she'll get referred to an orthopedic specialist. But I'm sure similar in India as it is in Canada, many of our orthopedic specialists are overwhelmed with referrals for knee osteoarthritis, which haven't gone through any of the early management process. So in summary, this ORC group guidelines, they've tried to come up with a patient-centered multimodal algorithm, based on clinical status and the patient's comorbidities. Of note, topical Nsaids strongly recommended, as are intra-articular corticosteroid and hyaluronic acid. So we have a significant role to play here early in what is a significant disease burden. And as I recommended, some of these other changes. So that's ORC. The second guidelines I just wanted to talk through briefly is our Canadian experience. This is the second guideline, which came out last year in July. And this is from the Canadian Arthroscopy Association on intra-articular injections. Just a comment about Canada, here in Alberta where I practice, there are many clinics set up where we are able to do these injections and actually bill for it in the clinic. In other areas across Canada, many of the radiology clinics are unable to bill for these injections. So I'm not sure if you have similar issues in India, but in Alberta, we do far more injections than any of our radiology colleagues across Canada. But it's interesting here that this guideline comes from orthopedic surgery. Most of the other provinces, the orthopedic surgeons, many of them are doing these injections. Nonetheless, this is a collaboration with sports medicine, the arthroscopy, and arthroplasty orthopedic surgeons coming out with these guidelines. And these are the main injections that they're talking about. So less about the more systemic and core treatments, but really about specifically the intra-articular injections. There are 5 recommendations, which I'll just walk you through. But notably, as with the ORC guidelines, corticosteroids now has high strength and good evidence for injection for relief, similarly to the ORC guidelines for short-term and up to moderate pain relief. There is some restoration of function. We know it's cost-effective, and this should be involved early in treatment for early knee OA and moderate knee OA. There are a few, I'll talk about the Cochrane review in a moment. We do know it's effective for grade 1 and grade 2, Calgary and Lawrence knee OA. Just a note here about repeated injections, and I'll talk about that in a moment as well. So the Cochrane review from 2015 was a large player in these guidelines. There are 14 new trials added for a total of 27 since 2004. And basically we're seeing that with intra-articular corticosteroid injections, it's better for sure than controls for pain reduction. Moderate benefits early on, and then smaller effects as you get out beyond 6 weeks. By 26 weeks, no effect. We know in our practice that patients certainly have improvement, but by 12 weeks, most of them are returning for a repeat corticosteroid injection if they can. So the Canadian guidelines are that intra-articular corticosteroids provide moderate improvement in pain and a small improvement in physical function. This is a good place to start. This should be early involved in NEOA, but limited benefit after 6 weeks. And a lot of that is because of the trials involved. This article by McClendon is just important to note because you'll be asked by your patients or your colleagues about this. This is a treatment where they had repeated injections with saline and triamcinolone, one of the intra-articular steroids, and they looked at the amount of the cartilage thickness here in millimeters, baseline and over 2 years. They looked at the pain score and function as well. And what they noted was that intra-articular steroids surely provided an improved pain score early on, but that the function between steroids and saline was of limited benefit or limited difference rather up to 24 months. And that is important. Sometimes we're finding patients will have one knee injection and they can be very effective with steroids. Sometimes repeated steroid injections become less effective. Perhaps that's because there's less inflammatory component, less synovitis in the joint. I'm not sure that we know entirely. I think there's too many different types of NEOA. But what was notable from this study is that the cartilage thickness did decrease with steroid injections. So the concern is that repeated steroid injections will thin the cartilage and progress knee arthritis, which is kind of counterintuitive to what we're trying to get to. The other important thing is saline in a few other studies that I won't get into great detail here, but I'll talk briefly at the end. Saline does have effect in the joint and is no longer considered a good control. So the second recommendation from the Canada group is regarding hyaluronic acid. Again, we have strong evidence here for mild to moderate NEOA for these injections. They improve pain relief and they restore patient function. There's two or three notable, which hyaluronic acid would you inject for these patients? And I'll talk about these in a bit more detail in a moment. But what's most important is those with higher molecular weight, at least 3,000 kilodaltons, have more effect in terms of pain relief and function, and they're superior to the lower molecular weight hyaluronic acid. The second point is there's some that are considered cross-linked, which I'll talk about as well in greater detail. Those are also more effective up to 26 weeks. These all, however, have a very safe risk profile. Adverse reactions, which I'll talk a little bit about in my next webinar. Infection certainly is always a risk, but there's this unusual granulomatous inflammatory response that can be an up to 10% reaction, which you should be aware about when you're doing these injections. But overall, this is temporary. Obviously, infection is something to be avoided, but this granulomatous inflammation is temporary and patients do quite well. So just a few, Dr. Bondari is an orthopedic surgeon here in Canada, and he went back through and did a meta-analysis. And there's a few important things to highlight from this study, which also plays into our Canadian recommendations. They did a meta-analysis of RCTs, looking at intra-articular hyaluronic acid therapy over the last 5 years, and looking specifically at the efficacy, the safety, and looking at molecular weight and cross-linking. So the summary of the efficacy is that all of these studies, really pain is the main concern for patients. There is a significant improvement in pain for all hyaluronic acid injections, regardless of the treatment and the trial quality, etc. So there are consistent and statistically significant improvements in pain, function, and stiffness outcomes for up to 26 weeks with these injections. And I'm just going to talk briefly about each of those. So with pain outcomes, On the side here, showing that the higher this bar graph is, hyaluronic acid is better than a control. These are the different studies. And just to show you the duration, so these studies went out to 26 weeks. Most, however, went to 13 weeks. But you can see across the board here that hyaluronic acids for pain, more effective than control, which we've seen already. Function outcome, specifically with the one study that went out to 26 weeks, we are seeing improvement in function. Perhaps when I go back here to pain, maybe less effective hyaluronic acid for function than for pain, but there is some benefit. And finally, stiffness, probably the least responsive to hyaluronic acid, but certainly the one study from 2015 shows a good solid response and better than control. Comment here about molecular weight of these hyaluronic acids, and I'll show you some of the different types that we have and use and which ones are the ones with the higher molecular weight. Two of the studies in particular looked at molecular weight. Again, on the side here, those with higher molecular weight were the blue, and those were shown to have a better effect than those with lower molecular weight. So if you're going to choose a hyaluronic acid for your patient, the injections with higher molecular weight are more effective for treatment in pain. Cross-linking again, I'll talk about the different ones that are cross-linked. Those that are cross-linked here in the blue, more effective than those that are not cross-linked here in the yellow. So ultimately in the guidelines, both in RC and the Canadian guidelines, hyaluronic acid injections of greater than 6,000 kilodaltons are more likely to affect the outcome and be more effective for patients' pain. And avian origin is more effective than non-avian origin. Just a brief comment for those of you who are not familiar with hyaluronic acid injection. There are various proposed mechanisms. What I like about these injections is regardless of whether the patient has mechanical symptoms, a dry knee or a wet knee, all of these tend to be quite effective for all the pain, the knee osteoarthritis groups. So there's protection of joint tissues, there's an analgesic component. Certainly I explain to patients it's like a machine oil, there's a mechanical benefit. This undoes some of the pressure on the subchondral bone. There's an anti-inflammatory component. And it actually, by putting this injection in the joint, it's thought to stimulate the patient's own joint to produce more proteoglycan synthesis. So the products that we use in Canada, I'm not sure if you have different names or different types in India, but the ones that I want to highlight, the ones that are cross-linked and higher molecular weight, this is 3,000 kilodalton, this is 6,000 kilodalton. So these are the patients, the ones that we typically recommend are Synvisc or Synvisc 1 and Durolane. What I will tell you is that Synvisc is, and I can talk about this in more detail in the next webinar, Synvisc is quite a bit less viscous. It's easier physically to inject. The Durolane is a smaller volume, but it is very hard to inject. You'll need a larger needle. We also have found patients tend to respond with this inflammatory reaction to some of the thicker or more viscous hyaluronic acids. Again, I'll talk about that more in my next talk, how to get around that, how to manage that. These are the two cross-linked, and these are the ones that we predominantly recommend based on these new guidelines. The final few things I just wanted to mention, the clinical importance of pain benefits to the patient. We talked earlier about saline having an effect. Well, you need to tease out from some of these studies, and Dr. Banneroo has gone through and done that, as has Dr. Bandari, to look at the minimum clinical importance threshold and separate that out. And when you do that, you can see all these other treatments that have been shown in various studies or traditional treatments. They're far less effective compared to intra-articular hyaluronic acid and intra-articular corticosteroids. These are far more robust. It's a good early treatment for our patients, and we should be taking full advantage, certainly as radiologists. And again, just highlighting these: pain, function, and stiffness relative to other treatments. Well, what about Nsaids or placebo? Well, you can see that the intra-articular hyaluronic acid and steroid are more effective for pain, for function, hyaluronic acid, and hyaluronic acid is more effective for stiffness than all these other treatments. Again, we know these should be treated early, and in my experience is more effective as well for treating patients. Just one or two other few studies you should be aware of. This one from JBJS, non-operative treatment, again coming from McMaster, an orthopedic surgery group, talking about the intra-articular placebo effect. And they were looking again at this minimally clinically important difference in intra-articular hyaluronic acid, trying to tease out all the different meta-analyses from all these different years. And there's just, I'll show you briefly. Here are the treatments that they've shown from all these other studies from different treatments labeled across the bottom. So here's PRP, very impressive treatment. Here is intra-articular versus oral placebo on the far side here on the right. In the middle, you have intra-articular corticosteroids. And then the intra-articular hyaluronic acids, these are the larger molecular weight, and these are the middle molecular weight hyaluronic acid. When we tease out the effect of placebo, suddenly some of these treatments become more robust, and lo and behold, those that are more effective for these patients are the ones that we have a role in providing. PRP, which I'll talk about in a moment, hyaluronic acid, especially now the higher molecular weight, as well as steroids have more significant effect. So it is important to take away the placebo effect and note these intra-articular treatments are very effective. So the conclusion is that from this one study is that while many non-operative treatments provide statistically significant improvements in pain, the greatest effects were those that we can provide for them, which are intra-articular injections. And they did note that while PRP, platelet-rich plasma, provided the greatest point estimate, again, as we discussed earlier, some of the research is not robust enough in order to provide specific recommendations currently. And again, we're looking for higher kilodalton, the higher molecular weight injections. So the Canadian guidelines, in summary, came out supportive of steroids and hyaluronic acid. The one benefit of steroids in the joint and longer duration because you have the benefit of hyaluronic acid. This was given a strength of B for fair evidence. We are finding we use this quite commonly in patients. It's a single injection and it's appreciated. And basically that just sums unfortunately there are limited combination studies, but we'll see more of those coming shortly. Just a note about PRP and hyaluronic acid, there are some combinations, limited results so far in low quality study design. This is just showing the sooner response when we combine the treatments compared to hyaluronic acid alone. That corticosteroid gives you a bump up in terms of your treatment, but really they're very similar later. There is some relative improvement in a combined compared to hyaluronic acid alone. PRP and cellular-based therapies, the Canadian group felt that we have seen improved pain and function outcomes up to 1 year for PRP for mild to moderate OA. So we actually do a fair number of PRP injections in our practice. Patients pay out of pocket for these, and we have had some good outcomes. The other ones, these are bone marrow aspirate injections. There's insufficient evidence at this time, and we don't perform these. Actually, the Canadian government has asked that we stop injections. There's been some concern about the quality of these injections performed. PRP is still allowed at the moment in Canada. These other ones are on hold. So the Canadian group conclusions are that intra-articular injections are the most effective in mild to moderate knee OA. That brings radiologists to the fore in the treatment algorithm. Corticosteroid injections, short-term moderate pain relief, restoration of function. We start all of our patients off with a corticosteroid injection. You know, if they have some component of an inflammatory OA, if there's some synovial thickening or joint effusion, this is a safe place to start, and it's cheap. It's also covered. Hyaluronic acid is where we would move next. We know that this provides pain relief, improved function, and decreased stiffness for up to 6 months. In Canada, we find that many of these are covered by insurance companies. Some patients are willing to pay out of pocket for them. And remember, if you're going to choose one, the higher the molecular weight, so the Synvisc or the Durolane, and the cross-linked, again, Synvisc or Durolane, are more effective. The hyaluronic acid and corticosteroid in Canada, this is called Cingal. It has a rapid onset of action and lasts as long as the hyaluronic acid, obviously. PRP is safe, but we cannot recommend currently by the Canadian group for or against, but it has shown some potential. I'll talk about that a bit more in the next webinar. So summary today, I know some of it's a bit dry, but I think it's important just to understand a lot of the guidelines here are coming from our orthopedic colleagues and from multidisciplinary approach. So if we're going to be involved, it behooves us to be aware of what the guidelines are suggesting and at least be in line with them. We know NEOA is common, increased burden of disease. There may be an overlap with inflammatory and crystal arthropathy. Perhaps that's why some patients respond better to one pathway than another. Both these newest two guidelines, which are quite robust, support a sooner intra-articular therapy for management. So there is a significant role here for the radiologist. In the next webinar, I would plan to talk you through the different injection types, portals, best approach with some of our experience. Again, starting with corticosteroids is safe and moving on to hyaluronic acid. Or you could try a combined injection. So thank you for your attention. I know it's late there. I hope you have a nice weekend. I'm happy to answer any questions.
Thank you, Dr. Sarah. So all the attendees can ask their questions they can write their questions and answers area. You can write it and Dr. Sarah can answer it. So Dr. Sarah, I'll start with one of my questions that you always prefer combination of steroids and hyaluronic acid, or so what is the criteria where you will say that I will first start the steroids, then after some time I will give the hyaluronic acid, and what are the patients in which you straight away go ahead with the combination?
So our practice is interesting in that patients often come to us with requisition for a specific injection, or family doctors are sending them for our advice. And in our experience, most patients do have some element of synovial thickening, even if they don't have a frank joint effusion. If they have pain, often it's related to synovial irritation. So our preference is to perform a corticosteroid injection first. It's covered by the provincial government here. It's cheap if it's not. And it gives the patient time to settle down that knee. Any inflammatory component tends to settle. And then when their symptoms come back, which is usually by 3 months, at that point, we may consider a second injection or go straight on of steroid rather, or go straight on to hyaluronic acid. At that point, the knee should be settled down. So I do like the combination therapy because it's a single patient visit, it's a single injection. But in my experience, I think having early treatment with steroids and then coming back for hyaluronic acid has been the most effective.
So can I just ask a question, Sarah?
Of course.
Or rather a quick succession of questions. So I see in the papers that obviously WOMAC is the standard scoring system and the rating system used. So rather than KL, you use WOMAC in your daily practice, I gather. Is that right?
We always look at the x-rays coming in, but actually, despite the literature showing, obviously improved pain and function earlier in arthritis, a lot of the patients coming to us, even if they have advanced OA, the only alternative is orthopedic surgery and arthroplasty, which in our environment is a 2-year wait list. So we do injections with steroids in all patients of all types, regardless of the degree of the Calgary-Lawrence scale.
I was asking what scoring do you use in your in preference?
So because we're a radiology practice, we use the Calgary-Lawrence. Most of the literature that I've shown you is based on clinical practices with follow-up WOMAC. That's how they show the pain outcome score. But we go based on, just talking to our patients when they come in, and we give an immediate pain score and then follow up with them to see if they've responded, and they'll tell you quite clearly.
Okay. And the way that you assess your synovial thickening, so I gather that you would do an MR before deciding on these in routinely, or you use MR selectively?
We use MR selectively. Unfortunately, compared to our American colleagues in Canada, MRI, they're trying to limit it more and more. And one of the contraindications for MRI here is NEOA, which is unfortunate.
Of course, yes. No,
It's
it's
expensive.
same in the UK. Yes, yes.
Yes.
Okay.
Yeah.
So we do sometimes use ultrasound. Ultrasound is useful to look for synovial thickness and joint effusion. But again, that's an added cost. So really, if a patient has any element of NEOA or is presenting with typical symptoms, even in the absence of an effusion on x-ray, we would go ahead with steroids. So we don't always have a good measurement of synovial thickness before we start.
So, okay, and just one more slightly controversial question.
Yep.
That was a fantastic talk on intra-articular therapies for OA. How do you place these therapies in relation to what is coming out of Japan in terms of Ocuna papers, as well as medial genicular nerve blocks? Where do these things sit in terms of endovascular treatment of medial genicular artery treatment versus nerve blocks versus these intra-articular injections? Where do they sit into the algorithm?
Yep. No, and that's a great question. And certainly with a group and a panel of interventional radiologists in our practice here, there are two approaches we have. We typically start all of our patients on intra-articular injections early. As I said, they're cheap, they're accessible. It confirms the diagnosis in many cases. We know that they respond to it. And now we're starting to offer some of the medial geniculate artery embolization. We know that there may be some benefit there. There's also some talk about nerve blocks. If we can provide patients with more durable response, that's great. In our environment, those tend to be costly. They're done by interventional radiologists, possibly orthopedic surgery in conjunction. So and what we're finding is the outcome from those so far might be a year or 2 years, but that's still quite a costly treatment relative to a knee replacement. So we find in our experience, patients end up predominantly in the intra-articular injections until we know more about some of these, I would call them a third level of treatment, if you will, before surgery. And the last point I wanted to make is some of our colleagues are also looking at chondroplasty. That's something we're working in conjunction with the orthopedic surgeons. They can use some of our fluoroscopy suites to perhaps perform this. So we're trying to evolve sort of as a multidisciplinary approach on the back end for those other treatments which patients should get those more expensive treatments before going on to surgery. I'm not sure we have that information yet and have identified those phenotypes yet.
Great. Thank you very much. Thank you.
Dr. Sarah, if I could ask a question.
Of course.
What are your contraindications for corticosteroid therapy? Which was the patient you would avoid it in?
That's a great question. So one of the things that we do in our practice, certainly one of the biggest problems we see with injections is patients who are having steroid flare. It's a bit sometimes death by steroids in our environment. Family doctor will refer for, a small joint in the hand injection, lateral epicondylitis, the patient has NEOA. And so we've tried to be stewards in our environment to make sure that patients have only a total amount of maximum 300 milligrams of steroid a year. So one of the contraindications would be they've had too much steroid. I would say that is the most common. It's our job to try to educate these patients and move them into, for the joint injections, hyaluronic acid. We know that's more durable. We don't have the steroid issues. So that is, I would say, one of the main contraindications that we run into is just they've had too much steroid. And nobody keeps track of it except for us. And it's arduous, but I think it's important. The second indication, obviously, if there's concern for infection, which we screen our patients, do they have fever as part of the consent? There is no question that we have put steroids into a joint that's been infected, and we've seen the patient's knee get infected more so. How do you avoid that? I think in the absence of joint sampling, which we know is not entirely reliable, I'm not sure you're ever going to avoid that entirely, but I would say that our complications of injections due to pre-existing infections is what we believe are very minimal. So I think general screening for fever, for acute swelling or redness is important. Really, other than skin inflammation and infection at the site, we don't have a lot of other contraindications.
Is diabetes a concern?
Diabetes is a concern, and we actually have a nurse as part of our clinic who will help these patients manage. So we do let them know with any steroid injection that their sugars will rise, and we do give them some guidance in advance. And so we walk them through adjustment for insulin and what to expect, and they'll call us back if they have any issues. We also let their family doctor know that they should keep a close eye on it.
Yeah, thanks.
Sarah, one question.
Yes.
When you were giving just steroids and then you were just giving hyaluronic acid, when you combined it, did you see any difference in the period of relief of pain and symptoms?
Not the duration overall is the same because that's really earmarked by the hyaluronic acid. The corticosteroids are the same as if we did steroids on their own. So really it's just a combination of the two. It's the same earlier response of steroids. I should note when we put steroids in on the one graph I showed you with the combined therapy, it showed response at 2 to 4 weeks. Most of our patients are having a response within a few days. We tell them expect maximum benefit by 7 to 10 days. But we also do, and I'll talk more about it in our next webinar, when we do these injections, we do put a little bit of intra-articular anesthetic in. And it's almost by lubricating the joint. Patients often get pain relief right away. So typically they leave with a little anesthetic in, and often by 24 to 48 hours, they're having pain relief from the steroids. The hyaluronic acids in isolation can take up to 2 weeks. And it is sort of more of a rebalancing of the joint of that product.
So you mean to say by adding both of them together, your onset of relief would be faster?
Your onset of relief would be the same as if you gave just steroids alone.
Yeah.
And the duration of relief would be the same as if you gave just hyaluronic acid alone.
Okay. Thank you.
Pleasure.
Sarah, there are a couple of very interesting questions on the Q&A.
Okay.
One of them is from Dr. Chandan Das, and that is on the what is your experience of using growth factor concentrate, GFC, in this setting?
Okay, so we actually haven't used that yet. Certainly we're limited in Canada based on what Health Canada has approved, and that's not yet an approved product, but we are seeing it potentially shortly. So I will have more information in future webinars.
Lovely. And then there is another very interesting question from Dr. Saeed Zoharul Alam, and that is any indication of hyaluronic acid or steroid injection in Chondromalacia patellae?
Interesting. I would say we certainly tend to use hyaluronic acid, yes. Steroid, less so. It's a softening of the cartilage. And as I showed you the one slide for hyaluronic acid, there's a thought that hyaluronic acid injections will promote the need to produce more proteoglycans, which would be a wonderful byproduct. So we're hoping that some of these hyaluronic acid injections will actually help fortify and strengthen the underlying cartilage. So yes to hyaluronic acid. I would avoid repeated steroid injections in that population.
Fantastic.
Sarah?
Yes.
Yes.
Dr.
Hello.
Hello.
Yes, Femoral.
Yeah. So my question is based on your practice. Now, how is the tough battle there? The orthopedic guys injecting, the anesthetists here in India are quite active, and they're, injecting steroids and hyaluronic acid and PRP.
Mm-hmm.
How does the radiologist kind of, fight this tough battle?
That's a great question. And I think it behooves us all to, as I mentioned earlier, to stay involved in this early on. As I mentioned, I've put my name forward. I sit on a bunch of committees with orthopedic surgeons and so forth. And I'm often the only radiologist at the table. I think it's important. There are some studies that will show you the effect of a blind injection, which is what most of our colleagues that you've mentioned are doing, versus either ultrasound, or in our practice, most of our joint injections are done under fluoroscopy. We use a bit of dye, and we can show that we're in the joint and that the product will move around, the medication will move around the joint safely. Our outcomes are much better. We have a better safety profile. So I think that's really important when, and not that an orthopedic surgeon can't inject a knee. A knee has got to be one of the easiest joints to inject, but so certainly some of our colleagues will inject in their clinics, as for example with subacromial bursa, but otherwise they almost entirely defer to us, knowing that the chance of them getting into the radiocarpal joint, for example, is limited, and they don't have the confidence. So we've built a fairly robust practice that's accessible. Much of it is covered, and our orthopedic surgeons are busy seeing patients, getting them ready for surgery. They almost don't have time to do some of these injections. And I would say many of our local orthopedic surgeons are also, they don't have the time to keep up on the evidence of these type of injections. What's appropriate, what's the right algorithm, come back to my office in 2 weeks. It's not really a possibility here. Sports medicine doctors are seeing patients and doing some injections, but again, they don't have ultrasound or fluoroscopy at hand, and they trust us. And the final comment I would make here is that when patients pay for something, we offer hyaluronic acid effectively at cost for the patients who do have to pay for it, which is, I know that makes some of our colleagues a bit angry, because I would say many patients make a lot of money on the back of hyaluronic acid, but we know it's a good treatment and we want to make it accessible. So if the insurance company won't cover it, then we provide it at cost. But if you're going to charge a patient and you're doing it blind, I think the patient should be aware that there's a chance that the hyaluronic acid might not get into the right part of the joint. It might not be effective. So we've seen, for example, in our practice, patients who've had these injections in an orthopedic surgeon's office, and they'll say, oh, it didn't work. And I'll say, okay, well, let's try it again. And it works because we got it in the right spot. So I think that's a huge argument in support of radiologists.
So to the extension of this question, this is a guided procedure, would be a beneficial thing to have a guided procedure. And if somebody wants to learn this procedure, how long do you think they should spend time with you?
Well, Dr. Thacker, who had come over, spent a day with me, and you guys are interventional radiologists. You have the needle skill. The next webinar I was going to show you was, this is not rocket science compared to what a lot of you probably already do. This is fine needlework. We do a lot of tendon needling. Joint injections, I always say a knee injection is a bit like playing darts. It's very easy. You could get to it mostly from across the room. I don't say that with patients in the room, but some of the other injections, the approach, the angle makes a difference. It can, there's no question. Most of these injections we do in 5 minutes. I walk into the room, prepare the patient, do the injection, and I'm out 5 minutes later. Some of them get complicated. So I think having the experience in what normal injections are, and there's some good resources. For example, some of the musculoskeletal, I can provide some good papers in terms of review, but hands-on, the people that I've taught, orthopedic surgeons or sports medicine, usually a day or two and you're comfortable. So
great. So just one little comment on Vimal's point about, see, the bottom line is, Vimal, like in every other branch where IR shares the turf with the other clinical specialty, we know that there are two issues. One is fewer numbers of us, number one. Number two is that if you're not in the game, you're never going to be considered part of the turf. So I think the first thing, as Sarah is saying, is that we need to be in the game. How many of us actually do this? We all can do this, but we don't do this because we are also occupied with, doing all our vascular work and all our non-vascular work. But these, the young bunch of IRs in India, Sarah, you would be glad to know, at least there are 10 or 15 of them who actually are out in, not in the big cities, but in tier 2 cities of the country. And they are actually, they've taken this on and they are running a very, very successful practice. And once you start up and actually demonstrate to people that guidance is good, then even orthopedic surgeons would refer to you. I'm sure about that.
Just as
I mean, the whole idea of organizing this was so that, you know, the younger lot take it up, and, you know, it's something which we should pursue and probably practice.
Brilliant. And I think,
I say one very important point that was made in this presentation was, if you do not understand the clinical background and the patient's problems, you probably are not the right person to take care of this, because these are chronic patients. So whatever
Rojan, I'll just add to exactly what you said. I think what Sarah showed us today is that you need to be able to speak to your orthopod or your pain physician in the same language as they do. Language as they do. And this is the information for the guidelines and where does the evidence stand is you need to know it as much as they do. And that is the key aspect of, I think, what was shown today.
Absolutely.
Can I take, Sarah, do you also practice other kind of pain managements, also nerve blocks and any of those in cancer patients?
Yes, we do. We actually
trauma and chronic.
Yep. It's interesting, actually. I would say our practice, I've been practicing here now for 16 years. And as I mentioned, I'm a musculoskeletal radiologist by training. And in my fellowship, I probably did maybe 3 injections a day. And now I'm doing upwards of 50 a day. Yes, joints, but a lot of them, the largest change in my practice over the last few years has been in peripheral nerve injections. So we do a lot of spine work, you know, transforaminal and intralaminar epidural injections. These are also important, obviously, a huge radicular and back pain problems. And that's a whole separate patient population. I have some examples in a follow-up webinar for you. But yes, peripheral nerve, tumor patients and who have chronic nerve pain, we do some CT guided. Actually, some of our interventional radiologists, one of our younger colleagues, I recently guided through, there's a good paper on CT guided pelvic nerve blocks, which I can share with you if you need. But these are very important. And I think having the confidence, like I said, you know, your needle work will be not the issue. It's getting the referral for these patients. And I would say the nerve injections are the fastest growing component of our work at the moment.
Yeah. I think that's a very good summary.
Dr. Deep has to say something. Dr. Deep.
Am I audible?
Yep.
Yes.
Thank you, Dr. Sarha. Very nice presentation and even more interactive session. And I just wanted to share a few things in this. We are actually using PRP injections, corticosteroid, hyaluronic acid, and also started doing genicular artery embolization. So as you said, Turf Battle, we actually a few years back started a project under UKRI and with orthopedic surgeons and started imaging osteoarthritis problem of India. And then it was related to partial knee replacement. So after that, we most of the patients who are coming for hyaluronic acid, they already had multiple years history of corticosteroid injections blindly done by orthopedic surgeons. So we directed with orthopedic surgeons, we shared this thing that we are doing MR arthrogram, frequently doing MR arthrogram injections in the knee. So under ultrasound guidance, if we do, we can compare the exact results because the drug, whatever we are injecting is going right in the knee joint. So we started doing, and then started doing ultrasound contrast also to see the synovial wall thickening and correlation with other imaging modalities and intervention modalities. In fact, like after genicular artery embolization, we can compare the thickening and the response in that. So what I wanted to say that I'm really more interested in knowing other interventional procedures that you are doing and comparing. And sorry, please. No,
go ahead. I'll let you finish.
Yeah. And initially, actually, orthopedic surgeons, they were not interested in MR because we all know that osteoarthritis grading, treatment, and all these things are based on plain X-ray and various Studies are also available. But when we started doing cartilage imaging and other things, then orthopedic surgeons started interest in all these imaging and correlation also. What you said that the corticosteroid and hyaluronic acid, in hyaluronic acid, the response is even not for 6 months. We have noted only 3-4 months, but definitely in corticosteroid, there is dramatic relief in few days. But in hyaluronic acid, it takes some time. Regarding PRP injections, as many persons are using the different type of PRP depending upon the labs, the way it is prepared, and the amount of the material which is injected. So please now please share your view.
No, and that's exactly it. My follow-up webinar that I was planning to do next week was sort of a discussion more of our typical algorithm and some of the things that we're looking at. You know, we're pushing hard to be part of multi-center trials, which I think are important, exactly as you said, for comparison of these different treatment types. I think of knee osteoarthritis, it's sort of like a tidal wave. There's so much of it out there, and it's being either mismanaged or, as you've said, patients get stuck in an eddy of corticosteroid injections. And what we've tried to do is be a resource for our colleagues to say, send them to us and we'll try moving them along to the next stage as much as possible. I think that's really important. It's, you know, cheaper ultimately on the healthcare system. It prolongs or pushes out arthroplasty, which is also cheaper in the long term. And, you know, I think the more that we're involved, and as you say, I think that's wonderful that you're doing some of the MR arthrograms and the contrast enhanced ultrasound to look at the synovial thickness. These things are really important to be able to, first of all, try to separate these patients. Which patient should go on to geniculate artery embolization? Which patient might respond better to a few repeated steroid injections before hyaluronic acid? And as I say, I'm not sure that we know the specific phenotypes well enough yet, and I look forward to more research in that. And there's no doubt that we become a bit hamstrung when our governments are saying that MRI is not indicated or shouldn't be performed in these patients. It's critical, and we see that with our American colleagues. Certainly MRI scoring of arthritis is the most sensitive. They have a MOCS score that is used in most of the literature coming out. So perhaps in Canada, and specifically in our environment, we're just hitting a low point in MRI, but perhaps, and I'm hoping it will come back to the forefront in terms of, you know, directing appropriate therapy for this patient. The one other thing I wanted to mention is that, you know, we do PRP. We're trying a new injection that's just been approved in Canada called Nsaid. It's more of a protein-based approach shortly, but a lot of the biologic literature that we've actually relied on has come from the veterinary community, which interestingly, they don't have the same, you know, issues in terms of getting approval. And they use PRP and some of these biologics with great effect. And so it's an interesting whole other discussion. But I applaud your work, and I think it's really important, specifically the things you mentioned, working in conjunction with your orthopedic and sport medical colleagues, building those referrals and building, as some of your colleagues alluded earlier, you know, to become the source of knowledge and the resource center for referral and management.
Thank you. We'll wait for your second webinar.
I think Dolly had a question, I think.
I think there are two more questions pending. Is there any evidence for using mesenchymal stem cells as a regenerative process?
There is, but as I mentioned, similar to the bone marrow aspirate, the research is thin. It's not robust enough, and I don't think we have enough evidence. Certainly in North America, there's a bit of a full stop on some of these injections. It's considered a bit cowboy medicine. Some people in our world are naturopaths injecting in their clinic, you know, spinning down some of these biologic materials. And in Canada, the reason that these injections were stopped is because it was felt that we need to have a controlled environment and process for how these injections are done. But also there's some concern that perhaps some of these injections are causing tumors in joints. And so I think we need to wait and get a bit more information. As we talked about, some of the preparations are quite variable as well. So I don't think we have enough information yet.
one more question. How often do we repeat, whether say, what is your algorithm when you give steroids first? How often do you give steroids before you go on to hyaluronic acid?
That's a great
And
question. And again,
how often can you repeat at intervals wise, and how many times can you repeat hyaluronic acid?
okay, good question. And I laid some of this out in the follow-up webinar as well, but our algorithm typically is steroids. If you're going to, you'd start with an initial injection. If you're having hyaluronic acid injection, we typically advise waiting at least 2 weeks before a hyaluronic acid injection if you're separating them. If you're having steroid injections, we will, and partly it's based on our billing, you can have no more than 4 per year, which makes sense. And that's in any given joint. Steroids should last no more than 6 to 12 weeks. So having no more than 4 limits the dose. So there are certainly some patients who do not go on to hyaluronic acid, whether they can't afford it, they don't want it, they've tried one and it doesn't work. Hyaluronic acid injections, when we perform them, I tell the patients to go away and see how they do. Sometimes they last up to a year, sometimes 9 months. So rather than booking them back at a 6-month interval, the patients will call you when they need another injection. And the one other interesting fact about the hyaluronic acid experience is that sometimes you'll try perhaps a Synvisc in patients and they don't work. And it's disappointing. And but don't give up. Actually, if you try one of the other hyaluronic acids, again, I think this is phenotype based. I don't think we understand well enough. Sometimes you'll try another injection and it works very well. So I think the other key message is try different types of hyaluronic acid if the first one doesn't work. It's an unusual but recurrent finding.
And one last question: there is, when do you ask for a joint replacement?
Sorry, would you repeat that? When do I ask for?
So you are giving these intra-articular injections over a period of time.
Mm-hmm.
When do you say that, okay, now is enough and now you need to go for joint replacement? So that decision is taken by you or by the orthopedic surgeon?
That's a great question. We usually, if the patients are finding they're not responding, but even those with advanced end stage OA do actually respond to steroids. I would tell you that, perhaps their pain doesn't go from 9 out of 10 to 0, but it goes from 9 out of 10 to 2 out of 10. So even patients, we will carry them right up to the time of their arthroscopy, but we advise them, the surgeons obviously do not want to have steroids in the surgical field. Typically they'll say no steroids within 3 months of arthroscopy. And the other time that we will I'll suggest a referral to the family doctors if on fluoroscopy you're seeing advanced OA and talking to the patient, that they're responding to a lesser degree with repeated injections. In my report, I'll suggest orthopedic referral if it's not already been performed. I would tell you that most of these patients are already sitting on wait lists, waiting to be seen and assessed by orthopedic surgery. So it's a 2 to 3 year wait list. The only other caveat and important, I think, role that we have is identifying Avian. We see it less around the knee, more around the hip. But when we identify Avian before we do these injections, we have a setup with our orthopedic surgeons that they will see these patients urgently within 4 weeks, which I think is really important. So we sort of fast track patients through the system where appropriate.
Dr. Dolly, you have any question or suggestion?
No, I just want to thank you, Sarah. It was a very good session. And thank you for waking up so early in the morning and setting in and fitting into the Indian time of 5 p.m. And I have seen her working and her timings are just fantastic. She jumps from one room to the other in a span of less than 3 to 4 minutes. And she's out of her procedure and her perfection is definitely unbeatable. So yes, it will be great for having others also to come and see you and see you work there. It is definitely much more better when you see her doing live on fluoroscopy and using the ultrasound when she's doing her procedures. So thank you so much for today's session.
Thanks, Dolly. Nice to see you again.
Yes. Yeah, I think we would like to have you here during one of our national conference with some live cases.
Yep, that we can do. And I've certainly videoed cases before when we do injections. Sometimes it's easier just to see them in the room. And yeah,
I think next time just show them if you can. Couple of these videos.
yeah, I can show you some videos. And as I said, the next webinar I thought was more approach of, a case-based approach of some of the other ones that we do. Okay, other joints perhaps, but what about tendons, soft tissues, spine injections, just to give you sort of an overview of some of the treatments we do.
I think
Yeah, I think some videos will
be
also
great.
make it. Yeah.
We can book her for the next few weeks.
Yes.
He does more than 60 to 80 patients a day. So we can imagine her number.
I heard. Thank you, Charlie.
That tells us very importantly what scope exists in this practice.
Yes, indeed.
See, when I started doing back injections, I did them because nobody else was doing it. I didn't really want to do them, but I had more than I could handle in a couple of weeks. I had to train 3 other people to do them. It's a huge practice.
Yeah.
Thank you so much for making it clear. Thank you so much.
Well, thank you very much indeed, Sarah. I think that was fantastic. I think if you, I don't know whether you saw, there were about 65 attendees listening to you, and
On Zoom.
On Zoom, and I was reading the names. 90% are less than 35 years old. So I think it's going to be great for those youngsters. Yeah.
That's great. Well, lots of work to be done for sure. And happy to, we'll offline arrange another webinar for whatever you need. So
stay safe and take care.
And to you. Okay. Thank you for the opportunity.
Thank you.
Thank you
so much.
very much, Sarah.
Thank you.
Bye-bye.
Bye.